Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Shahad Murshid, your host for today's episode, and I'm joined by Reem Ahmed to discuss nephrotic syndromes. Let's dive right into it. So, Reem, why don't you start by telling us what nephrotic syndromes are?
Sure. Nephrotic syndrome is an umbrella term for a group of diseases characterized by proteinuria that is greater than 3.5 grams, hypoalbuminemia, edema, hyperlipidemia, and lipiduria.
Let's start getting into each type now with some cases, shall we?
Yeah. So in our first case, we have a 6-year-old boy who presented with sudden swelling around his eyes and ankles. He had no signs of infection, but his urine analysis showed significant proteinuria and no hematuria.
No proteinuria or hematuria. So, this doesn't seem like it's very severe, is it?
Nope, not really. This is a case of minimal change disease, or MCD for short, the most common cause of nephrotic syndrome in children. It is characterized by selective proteinuria and effacement of podocyte foot processes.
Okay, so it's mostly in children. But wait, what do you mean by selective proteinuria?
That's actually a really good question. In MCD, you only lose albumin in the urine, but not other proteins such as immunoglobulins. So selective comes from selectivity to losing albumin only.
I see. And what causes this disease?
Well, it has several associations that include respiratory infections, atopic disorders, and Hodgkin's lymphoma. It is also linked to HLA haplotypes and immune dysregulation.
Okay, so how does it even happen?
The pathophysiology of MCD involves excessive cytokine production leading to effacement of podocyte foot processes and loss of glomerular filtration barrier.
Oh, that's why our child in our case had proteinuria, because of the loss of the glomerular filtration barrier.
Exactly. I'm glad you're catching on now. Let's discuss some diagnostic clues. Firstly, on physical exam, you may see periorbital and peripheral edema, which is exactly what we saw in our case. He had swelling around his eyes and ankles. A blood test and urine analysis will show explosive proteinuria, hypoalbuminemia, and hyperlipidemia. On light microscopy, it will be completely normal, except for lipids seen in cells of the proximal tubules, which is why another name for MCD is lipoid nephrosis. On immunofluoroscopy, it will show negative staining for immunoglobulins and complements, which is normal. However, our distinctive feature is on electron microscopy, which reveals effacement of foot processes.
Okay, so in MCD, we think of proteinuria and effacement of foot processes. And how would we treat this disease?
The treatment of MCD is by corticosteroids, which thankfully, children seem to respond very well to it.
So it's steroid responsive. That's great news. Now, shall we test the audience?
Yeah, so a child presents with sudden edema and proteinuria that was successfully treated with steroids. What feature can be seen on electron microscopy of his glomeruli? The answer is effacement of podocyte foot processes, which is a key feature of MCD.
Okay, so MCD seems like a pretty mild disease. So what's the next nephrotic syndrome we've got?
Okay, here's the case. We have a 35-year-old African American woman with a history of obesity who presented with proteinuria, hematuria, and worsening kidney function.
Obesity, proteinuria, and hematuria? Sounds like FSGS?
Yes, exactly. This is a case of focal segmental glomerulosclerosis, or FSGS. FSGS is characterized by sclerosis of some glomeruli, but not all, and that's why it's called focal. And in each glomerular tuft, only part is sclerosed, rather than the whole glomerulus, which is why they're segmental.
Okay, so only parts of some glomeruli. And is there a cause or trigger to this disease?
It can be either primary, which is idiopathic, or secondary to conditions like HIV, sickle cell disease, heroin abuse, and severe obesity.
Wow, that's a lot of correlations to remember. What about the pathophysiology of FSGS?
FSGS involves podocyte injury and segmental scarring that leads to proteinuria and reduced renal function.
Alright, so we have podocyte injury. Got it. And what are some clues that can lead us to the diagnosis?
So the patient will likely present with edema, hypertension, non-selective proteinuria, and glomerular scarring on biopsy.
That sounds pretty intense. Is there a treatment for this disease?
Well, it's both yes and no. It's actually treated with steroids and immunosuppressants. However, unfortunately, it has a very poor response and prognosis, with 50% progressing to end-stage renal disease within 10 years.
Oh, so it's not like MCD where they responded really well to steroids.
Exactly. I'm glad you're linking things together. Alright, let's wrap it up with a question. What biopsy finding is characteristic of FSGS? The answer is segmental sclerosis and hyalinosis in the affected glomeruli. In our next case, a 50-year-old man presents with generalized swelling and frothy urine. Serology revealed antibodies against phospholipase A2 receptor, and a kidney biopsy showed thickened glomerular capillary walls and subepithelial deposits. This is a case of membranous nephropathy, a common cause of nephrotic syndrome in adults, which is characterized by subepithelial immune deposits along the glomerular basement membrane, which leads to the thickening of the capillary walls.
Okay, so subepithelial deposits. And what could cause such a disease?
The etiology of membranous nephropathy is again either primary, which is idiopathic, or secondary to infections like hepatitis B, hepatitis C, and syphilis, or other conditions like systemic lupus, malignancies, and drugs.
Hepatitis, SLE. Alright, got it. And how does this disease happen?
The pathophysiology of membranous nephropathy involves subepithelial immune complex depositions, specifically IgG, which leads to diffuse thickening of the glomerular capillary walls.
And how exactly would we go about diagnosing it?
Well, light microscopy appears normal in the early stages of the disease, but in late stages you'll see the capillary wall thickening. However, the key features are the spike and dome appearance seen on electron microscopy, the granular pattern seen on immunofluorescence, and the presence of anti-phospholipase A2 receptor antibodies seen on serology.
Oh, I see. So membranous nephropathy has a spike and dome appearance and antiphospholipase A2 receptor antibodies. Is this treatable though?
Kind of. The treatment mainly involves supportive care, with the addition of immunosuppressants for severe cases. The prognosis generally varies, but the presence of sclerosis predicts a poor outcome.
I see. Well, let's move on to a practice question now.
Okay, here it is. What antibody is most commonly associated with membranous nephropathy? That's right, anti-PLA2R antibodies. Our next patient is a 25-year-old woman with fatigue, hematuria, and proteinuria. Biopsy shows mesangial proliferation and thickened capillary walls.
It's like an overlap between nephritic and nephrotic syndromes.
Exactly. This patient has Membranoproliferative Glomerulonephritis, or MPGN for short, which has features of both nephritic and nephrotic syndromes. It is characterized by immune complex deposition, mesangial cell proliferation, and basement membrane alterations.
Okay, and what about the etiology of MPGN?
Like some of our previous conditions, MPGN can either be primary, which is idiopathic, or secondary to immune disorders, infections, and malignancies.
And what exactly happens in MPGN?
I'm glad you asked. The glomeruli are damaged by complement dysregulation, which happens due to subendothelial immune complex deposition.
What kind of immune deposits?
It depends on the type, so MPGN has two types. In type 1, there will be IgG deposits, whereas in type 2, also known as dense deposit disease, there will be C3 deposits.
Oh, so type 2 MPGN has two names. How cool is that? Okay, and what about diagnosis?
So MPGN has very characteristic tram-track appearance on light microscopy. This happens due to mesangial interposition, which creates a double contour basement membrane.
Tram track. Got it. And how do you treat it?
MPGN is treated with steroids and immunosuppressants. Unfortunately, it is quite progressive, and around 50% of patients develop end-stage renal disease within 10 years. Okay, now it's time for one last question. A patient with hematuria and proteinuria underwent a kidney biopsy, which showed a tram-track kind of appearance. What are the two possible immune deposits that may be seen in the glomeruli of this patient's kidney? Type 1 MPGN will have IgG deposits, and type 2 MPGN, or dense deposit disease, will have C3 deposits.
Alright, now let's wrap up this discussion by summarizing the key differences in nephrotic syndromes.
Okay, so we talked about 4 diseases that fall under nephrotic syndrome: minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, and membranoproliferative glomerulonephritis. MCD is most commonly seen in children, causing selective proteinuria and effacement of podocyte foot processes on electron microscopy. It is typically triggered by immune dysregulation like from an infection, and it responds well to corticosteroids. FSGS is characterized by segmental scarring of glomeruli, often secondary to conditions like severe obesity, HIV, or sickle cell disease. It leads to non-selective proteinuria and has a poor prognosis, often not responding to steroid therapy. Membranous nephropathy features subepithelial immune deposits along the glomerular basement membrane with a spike and dome pattern on electron microscopy. It presents with generalized edema and frothy urine and is commonly associated with anti-PLA2R antibodies. MPGN presents with a characteristic tram-track appearance and subendothelial immune deposits. Type 1 shows IgG deposits, while Type 2, which is also called dense deposit disease, has C3 deposits.
That's all for today on PodBites. Thank you, Reem, for breaking down these cases, and thank you all for joining us on this journey. If you enjoyed this episode, don't forget to follow us so you don't miss a single episode. See ya!